I would like to introduce myself. My name is Ahmed Agwa. I'm working in Rashid Hospital, Trauma Center. Rashid Hospital was built in 1973, and then the Trauma Center was built in 2006, which account for more than 700 beds, and even the emergency have the ability to receive 7 ambulances on row. So we receive around from 4 to 5 polytrauma patients every day, which usually come with lung injury, hypoxemia, and liable for intubation for a long time. So our topic is the prevention of post-operative pulmonary complication. Actually, we will stress on more clinical basis or recommendation that we can use every day to prevent the post-operative pulmonary complication. Post-operative complication actually is common as a cardiac complication, and it's actually causing a financial burden and in all over the world that is costing around the United States around $3.4 billion per year. The incidence is around 5% for general surgical patient, but it's around high as 20% in selected group of patient. And if post-operative pulmonary complication represent around 25% of mortality in the post-operative surgical patient. And if the patient developed post-operative pneumonia, the rate of mortality increased to around 10-fold. The spectrum for post-operative complication, including the hypoxemia, including bronchospasm, but atelectasis account for around 90%. And fortunately, it's self-limited in most of the patient. And the incidence of pneumonia is up to 15% in post-operative surgical patient, with acute respiratory distress represent around 0.2%. This table shows the risk factor for post-operative pulmonary complication. It is adapted from the guideline done by Samantha and colleague, and it is the most common guideline used till now. That is identify that the advanced age and the patient with more than ASA2 and the functional dependency is a very high risk, or it is supported by evidence that this patient is a high risk for developing post-operative pulmonary complication. Further, that we can divide the post-operative pulmonary complication into 2 groups regarding that whether it is a non-modifiable risk factor or modifiable risk factor. Fortunately, we have this modifiable risk factor that we will try to correct to decrease the post-operative pulmonary complication. Some of these modifiable risk factors, including the smoking, the presence of some comorbidity like COPD or asthma or congestive heart failure, and the presence of renal failure or diabetes and alcohol. The ARIS-CAT. The ARIS-CAT, one of the randomized control trial that listed 7 risk factors, including the advanced age, and it was found that the patient older than 70 have around 3 times greater risk of developing post-operative pulmonary complication than others. And these 7 risk factors, including the reduce the peripheral SpO2 and the previous respiratory infection within last month, and the preoperative anemia, and some factor like emergency surgery and longer duration of surgery. Gupta and colleague created the respiratory failure risk calculator, and in 2011, and even if it is available to calculate the respiratory failure risk, and it is available online, and there is also a mobile application that can be downloaded so we can calculate the risk of respiratory failure in some patient, and they put some of these lines that including the procedure and the ASA class and the type of surgery, whether it is emergency or elective surgery, and the preoperative functional status of the patient, and the presence of preoperative sepsis. So to prevent the post-operative pulmonary complication, actually, we should start by a careful preoperative evaluation to identify the risk factor, whether it is non-modifiable or modifiable risk factor, and lately that we can correct this modifiable risk factor. So careful history should be taken from the patient, and there is one study that shows that the association of preoperative physical fitness and physical activity with the occurrence of post-operative pulmonary complication, and it showed that the increase the physical fitness of the patient and increase the functional dependence that decrease the risk of post-operative pulmonary complication. With the physical examination, we should concentrate on the body habitus, including, for example, obesity, especially obese patient with a body mass index with more than 40 that will be accompanied by increased risk of post-operative pulmonary complication. And there is one of the clinical tests which is called the positive cough test, that we allow the patient to take one breath spontaneously, deep breath, and if involuntary cough happened at the end of inspiration, it is one considered of the productive of the post-operative pulmonary complication. More recently, the preoperative SpO2 is more considered rather than a result of arterial blood gas. So, for example, if the SpO2 was around below 90%, the post-operative complication will happen tenfold, with increased incidence of postoperative complication tenfold than the normal patient. One in the preoperative assessment, also it is listed in the guideline for Samantha and colleague, the correction of the preoperative anemia and the elevated blood urea nitrogen and hypoalbuminemia. And it was found that patient with hypoalbuminemia less than 30 gram deciliter was accompanied by the even failure of weaning of ICU in patient with respiratory failure. Other investigation that can be done in the preoperative period is the chest X-ray. Chest X-ray is not a routine investigation, and it should be, and in the American Clinical Guideline, actually it should be done in high-risk patient above 50 going for high-risk surgery. But even the presence of any abnormality in chest X-ray, including recent chest infection or congestion or even heart failure, is a strong predictor for the development of post-operative pulmonary complication. Preoperative pulmonary function, actually it is not routine investigation to be done, and it is not found that it is helpful in normal patient, but it will be helpful in a special group, high-risk group going for special surgery like the cardiac surgery or thoracic surgery. Surgical factor, one of the factor, actually it is non-modifiable, and really the surgery can affect the outcome and post-operative pulmonary complication due to the presence of pain or according to the incision, and even phrenic nerve inhibition, neuronal inhibition, due to traction of the abdominal viscera. So it was found that some surgery was associated with higher incidence of postoperative pulmonary complication. With open aortic surgery, the postoperative pulmonary complication account for around 25%. But the only thing that can be modified in the surgical factor is it was found that the laparoscopic surgery versus open surgery was accompanied by a better outcome and less postoperative pulmonary complication. So after our preoperative evaluation, and we can detect some of comorbidity that we will try to correct. Smoking, one of the factors that it should be corrected. Preoperative anemia, the type of anesthesia, which is sometimes it is out of our hand. Ventilation strategy, and the role of neuromuscular blocking agent and its reversal, neostigmine, in the postoperative complication, and the nasogastric tube application, and the preoperative and postoperative physiotherapy. This table shows some of the comorbidity that can be actually corrected, like the asthma should be treated with a bronchodilator or inhaler, and the presence of respiratory infection, if the surgery is an elective surgery, it should be postponed till any symptom or sign for infection should be relieved, and even congestive heart failure should be pharmacologically optimized by under cardiological care. One of these comorbidity is the obstructive sleep apnea, and it was found in this meta-analysis, it is done in 2012, that the patient with obstructive sleep apnea was associated with a rate of respiratory failure that twice the normal that the patient without obstructive sleep apnea. And in the obstructive sleep apnea, in this study, actually, on contrary of the previous study, that all patients of this study was permitted to apply 93% of this patient was applied on non-invasive ventilation, and it was found also that the outcome due to surgical factor is not related to the obstructive sleep apnea. So one of the guideline that is done in Britain and Ireland society that for the perioperative management of obese patient in 2015 that recommend for the preoperative application of nocturnal CPAP to decrease the incidence of postoperative pulmonary complication. Smoking cessation, one of the actually factor that one of the modifiable risk factor that it should be corrected, and in this study that ex-smoker for 4 weeks was compared with a current smoker, and it was found that the postoperative complication was actually reduced. Another cohort study that is including a patient in United States and even Europe and even United Arab Emirates that include around 67,000 patients. It was found that there is a relation between the postoperative pulmonary complication and the number of packs of cigarette smoked per year. The NICE in 2013, actually, they put a guideline for the preoperative cessation of smoking, and it is actually show a successful program that even that they meet the patient and try to support him psychologically and behavioral, and even give them the nicotine patch to try to cessate the smoking. And this program also showing cessation of smoking for 1 month in the post-operative time, not in the pre-operative time. Timing of the smoking cessation was of interest, and it was found that when the smoker in this study that if smoking was stopped for 4 weeks, the post-operative complication may account for 47%. But when actually the cessation of if the smoker cessation happened for more than 8 weeks, so usually the post-operative pulmonary complication incidence reduced to the half. Regarding the preoperative anemia, that the British Committee of Standard of Hematology guideline, they elicited a guideline for the management of the preoperative anemia, and it was found that the patient with preoperative anemia less than 10 gram deciliter having threefold increase incidence of postoperative complication. And they recommend, in order not to delay the surgery, the referral or the screening for anemia should be done once the patient has been referred for surgery. So many ways to correct the anemia, starting by the supplementary diet, or erythropoietin, or blood transfusion if the surgery was an emergency. The type of general anesthesia, one of the factors that's non-modifiable because there is a detrimental effect of general anesthesia that can be corrected, that even with the induction of anesthesia, atelectasis happen in the functional residual capacity reduced by around 20%, and the immediate atelectasis happen. But from different study, because if general anesthesia is avoided and the patient done with him, used for him regional anesthesia, it is the incidence of postoperative pulmonary complication is reduced. This study that support the intraoperative protective strategy, a lung strategy, if it is applied, that it will decrease the incidence of postoperative pulmonary complication. The protective lung strategy, it included the low tidal volume and even the application of PEEP and recruitment maneuver. In this study, actually, that it is a meta-analysis that is done in 2016. It was found that the use of low tidal volume was accompanied by decreased incidence of infection, and when it is accompanied by the PEEP and the recruitment maneuver, even the postoperative pulmonary complication was reduced, and atelectasis also was reduced. Actually, the definition of recruitment maneuver varies from different studies. And this table shows some of the recruitment maneuver that can be used during surgery. Another study that showed the effect of low tidal volume on the postoperative pulmonary complication, and it showed that the use of the low tidal volume, it will be prevent the incidence of the postoperative or decrease the incidence of postoperative pulmonary complication. Unfortunately, there is another study that is our meta-analysis that is done in 2006 shows that around 18% of the patient still ventilated with high tidal volume, in spite of recent study and evidence that the high tidal volume induce inflammatory response that aid for the incidence of acute lung injury. In this, the tidal volume actually calculation, it shouldn't depend on the actual body weight. It should be depend on height, or what we call the ideal body weight, and this is an equation to calculate the tidal volume. And this diagram from a study that shows the effect of low tidal volume and different level of tidal volume and different level of PEEP in anesthetized patient, and it was found that the patient with low tidal volume and low PEEP, there is a large area of atelectasis during the expiration and inspiration, and when low PEEP is applied, the area of atelectasis is decreased, but actually we can find that there will be cyclic opening and closing of the alveoli during the ventilation, and there will be area of high inflation during inspiration. With applying low tidal volume and high PEEP, fortunately, the atelectasis have been reduced, but the area of hyperinflation was increased. So which level of PEEP actually to be used during surgery? And it is usually of a debate. And this is a large retrospective study, including around 64,000 patients. And it showed that the zero PEEP to be harmful, and that the use of PEEP of around 5 with plateau pressure of around 16 was protective against post-operative pulmonary complication. And this is a Ravioli trial that it is the first to compare the low tidal volume, the low tidal volume with a high level of PEEP with the recruitment maneuver, and the low tidal volume with low PEEP with around 2 centimeters without recruitment maneuver. And actually, the post-operative pulmonary complication, it was around 40% and 39%. It means that there was no difference in the incidence of post-operative pulmonary complication, but with the high PEEP group was accompanied by the more hemodynamic instability and more use for the intravenous fluid and or vasopressor. So, protective ventilation strategy in obese patient. In obese patient, they are a special group of patients, and sometimes they are may require higher level of PEEP, and they also show higher opening pressure that reaching around 55 centimeter water. It is an area really of interest, the neuromuscular blocking agent and post-operative pulmonary and the incidence of post-operative pulmonary complication. In 1954, it was found that one patient in 370 patients received curare. This is the incidence of mortality. And it was and there was a dose-dependent increase in the post-operative complication with the use, even with the intermediate muscle relaxant. This finding is really supported by this study that the presence of residual neuromuscular blocking agent, it will be accompanied by higher incidence of post-operative pulmonary complication. Actually, more recently, there is some study that support that the intermediate muscle relaxant, which is recently used, its effect sometimes it's remain for even days after surgery. So we reverse the muscle relaxant with neostigmine, and we will show that this is a problem was solved. But actually, it was found that the neostigmine itself was independently causing muscle weakness, especially when it is given without muscle relaxation, or when it is given by higher doses, more than 60 mic per kg. That's why the nerve stimulation peripheral nerve stimulation monitoring should be done once the neuromuscular blocking or reversal with the neostigmine agent should be used. And there is area what's called the zone of blind paralysis. The zone of blind paralysis is defined that by our eye, we couldn't perceive that the four twitches, even if they are present, there is a fading. We will see it by our eye, it is equal, even of a TOF ratio of 0.5. So that's why a recent recommendation in UK and recent and call in US that they recommend the start of quantitative monitoring of the neuromuscular blocking drug and use of peripheral nerve stimulation in conjunction with neostigmine. And we was taught before that to administer the reversal neostigmine, once 2 twitches is appear. And the recent recommendation called that to administer the neostigmine only after the 4th twitch, and don't give it before that. And don't extubate the patient before 10 minutes of the administration of neostigmine. And if TOF ratio was less than 3, keep the patient anesthetized, and it is better to keep the patient anesthetized under TIVA. Even if the patient on inhalational agent, it was found that the TOF and the reversal or recovery from neuromuscular blocker was better under the total intravenous anesthesia. And this is the TOF watch, which is actually a recent recommendation to be used in all patients that will give us a quantitative monitoring for the neuromuscular agent. Regarding the nasogastric tube, we thought also that the presence of the nasogastric tube may help us and may help for decompression of the abdomen, especially when abdominal surgery. But it was found that patients that undergoing abdominal surgery and routinely nasogastric tube was applied was around 3 to 8-fold of the post-operative complication than if it is not used. So the recent recommendation that don't use the nasogastric tube even after abdominal surgery, especially routinely, but it should be used when it is only indicated, like the patient with intestinal obstruction or severe distension. The post-operative analgesia play a very critical role in the incidence of post-operative pulmonary complication, and it was found that the addition of epidural analgesia to general anesthesia significantly reduce the post-operative pneumonia, but unfortunately, it wasn't found that it changed the 1 to 30-day mortality. The preoperative physiotherapy, it is a new program, and a new study has been done for the intensive inspiratory muscle training in the preoperative period, not in the postoperative period. But actually, the evidence of this study is a little bit weak, and even the inspiratory muscle training, it's need the presence of physiotherapist, and even it takes training for around a session that take around 15 to 30 minutes. So it is quite found that to be routinely it will be expensive, and till the presence of good evidence or more evidence, it may be applied, and it is should be preserved if there is a patient with a high risk for post-operative pulmonary complication. Post-operative physiotherapy and mobilization, it is very important to reduce a post-operative pulmonary complication, and there is actually a program which is called the ICOF program, which including the incentive spirometry that to be done in the post-operative time 10 times each hours, and to cough and breathe and educate the patient and tell him to get out of the bed, and usually to keep the head elevated around 30 to 45 degrees in the post-operative period. So how to prevent a post-operative pulmonary complication? In the preoperative period, we will try to correct any comorbidity that's corrected, to correct the anemia, correct the hypoalbuminemia, and apply a smoking cessation program, and start intensive muscle training in high-risk group. Intraoperative lung protective ventilation strategy, low tidal volume to be used from 6 to 8 of the ideal body weight, and PEEP can be set according to the compliance, and the application of recruitment maneuver, the use of quantitative TOF is actually mandatory once the neuromuscular blocking agent is used. And don't reverse before 4 twitches, and even extubation, don't extubate the patient before TOF of 0.95. And avoid the high doses of neostigmine that may cause muscle weakness. In the post-operative, prophylactic application of non-invasive can be done in high-risk group or obstructive sleep apnea patient, and apply the ICOF program physiotherapy. Thank you.